So I've heard. So I've heard. So as you correctly introduced me, I am a general surgeon. I'm also president of the Cancer Society, which for me is just as important. I studied in Jamaica, so I spent almost 15 years at school in Jamaica, including my postgraduate studies. As a surgeon, as a resident in surgery, I found that there was an advantage to being female. Surgery is usually a male dominated field, and I was one of few females there, and I found that it was very easy, or a lot easier, for my female patients to relate to me. I could definitely understand their concerns, being mothers, being caregivers, being, the nurturing person in a family and in a household. And I could identify with the concerns about being diagnosed with any kind of breast pathology, and the fears that go through you as a woman when you think about your family and having to leave them and not being able to be there. So I've been called a breast doctor, but I want to say that I have spent a lot of time doing breast. And I've joined many of the breast associations and societies in the States. And I've continued to do a lot of general surgery, but my practice is mainly breast, or a lot of breast. So when I tell people that I like breast, I hope it's always taken in the right context. But I feel that if I can treat a patient, regardless of what kind of breast disease it is, and if I do it to the best of my ability, that they will have the best outcomes possible.
Okay, that is very important. As someone with chronic illnesses, I like to hear that kind of attitude. So today we are here to talk about breast cancer because it is Breast Cancer Awareness Month, and I want to start with one of the um, questions that we actually got from a participant when they registered, which said, "What is breast cancer?"
Okay, so cancer generally is an abnormality in the growth of cells and the way that they make more of themselves. And as the word before the cancer suggests, breast, it originates in the breast tissue. Now, our breast, and I know everybody's going to look down at their breast, male and female. If you start from the skin, and if you had piercing eyes that you could go all the way down to your rib cage and the muscle that lies above it, you will be able to see that the components or the parts of the breast include just the skin, the nipple. There are these pipes. If you look on or in the nipple itself, you will see some holes. All of those are pipes that lead from the inside of the breast onto the surface of the breast so that we can feed babies with milk. So the pipes, or ducts as they're called, lead to the sacs that make the milk. And so when we talk about breast cancer, we talk about the different origins of the different cells, and that's where the names for the different types of breast cancer come from. So
Yeah.
it is a cancer that originates in the breast. It's an abnormality in growth and division of cells that become their own powers. They don't listen to any of the instructions from the body to die at a certain time, to make more of themselves at a certain time. They take over and spread.
Excellent, excellent. So, you mentioned about the types of breast cancer.
Mhm.
Could you tell us the different types of breast cancer, or just highlight them?
Okay, so the more common ones are ductal cancers. As I mentioned a little while ago, the pipes that lead from the breast, the holes that you can see in your nipple, all the way down to the sacs are called ducts. And so if the origin of your cancer is from the cells in those ducts, so in those pipes, it's called ductal cancers. The sacs that make the milk are called lobules. And so therefore, if the origins of the cancer begin there, then they're called lobular cancer. A lot of times, a very different kind of cancer originates from the skin that is a little bit more difficult to diagnose. We call that inflammatory breast cancer. And what you get most times is not a lump like what we see in most breast cancers, but you get this thickening, redness, kind of flaky appearance sometimes of the skin or the nipple. And that suggests that the cancer is coming from those cells. So those are essentially the main ones that are coming, that are causing cancer in the breast.
Okay, so very importantly, like all illnesses, there'll be something that makes you go to the doctor. What are those signs and symptoms we should be looking for of breast cancer?
The most common, but it is not the only presentation, and I want people to bear that in mind, is a lump in the breast. Most times, and I have had to work on this over the years, most times, not all the time, that lump does not cause pain. However, we do have breast cancers that present as painful lumps. So the lump in the breast, 7 out of 10 times, is the first way that breast cancers present. And again, it may be painless or painful. The second most thing is probably a change in the look of the breast. So most times we refer to it as peau d'orange. There's a thickening, and if you translate that, it's the skin of an orange or the peel of an orange. So if you can think of an orange skin where you can see the holes on it, it's thickened, that's exactly how the breast actually looks. There may be changes to the nipple itself where there may be a discharge, and most times what we see is brown or red, but it can be any other color that presents as a discharge. Or if your nipple used to be sticking out, all of a sudden it starts pulling in. Now, persons whose nipples are normally inverted, you've had this from puberty, you do not have breast cancer, okay? That's not a sign for you. That's how your nipples are. If one looks like that and the other one is pointing out, but that's your normal, you do not suddenly have breast cancer, okay? So if there's a change. Sometimes you will also get glands under the arm or in the armpit. Those are usually what we call lymph nodes, but I think most people refer to them as just glands. Our lymph nodes help to drain the skin, the breast. There's millions of them all over our body, but sometimes they become enlarged, and sometimes that may be the only way that we know that there is breast cancer. And guess what? There are other times where there's absolutely nothing in the breast that you can feel or see, but you have breast cancer, and that's where the mammogram comes in as an important tool.
Okay, so before we go over to talking about screening, we had one of the participants ask if there is one breast that's more likely to have breast cancer than the other.
I don't know that, let me not say that. In my personal experience, I think the breast cancer occurs more in the left breast than in the right. But I don't know that there's anything that predisposes one breast over the other. I don't think that if you're left-handed versus being right-handed or stuff like that. So I don't know that there is a scientific predilection for one breast or the other. But in my experience, I have seen that probably left-sided is more common.
Okay. And then I had another question I wanted to make sure we address because this might be a common thing. Someone said, got a lump in my breast, an armpit pain. Is this a sign of breast cancer? Thought it was normal, but it keeps on hurting.
The majority of breast lumps are not cancer. Okay, so let me put that out there. To answer your question, if you've had this for a while, then you need to get it checked out. It can or it cannot be. If you've had it for a while, and I don't know what a while means to this person, and it hasn't changed, meaning it hasn't gotten larger, or if it comes and goes, for example, with your cycle, or if it comes and goes when you shave under the arm, those may be things that when you speak to your doctor might clue us into what exactly is going on. But if you have a lump in your breast, and especially if you have something going on under the arm, I'd suggest that you get it checked out. Commonly though, we do have people who have breast cancers with a lump in the breast, as well as glands that are enlarged under the arm. And that usually, if the lump in the breast is cancerous, that usually suggests that there is spread to under the arm.
Okay. So let's move on to talking about screening measures. So you talked about the changing of the skin on the breast and that sort of thing. So I always looking at my breast because, you know, we have to check those things. But sometimes I have seborrheic dermatitis. So sometimes it can itch, you know. So what are the different ways we can make sure we get the appropriate screenings, the ways we can make sure we catch the breast cancer early? and the different types of tests that you as a medical professional uses to test for breast cancer?
Screening, as you have very well put it, is to detect things early. Okay, so I always say to my patients, you all have no problems going to the health center or to your doctor, holding out your arm and saying, check my pressure, check my sugar, because I want to know before I get to the point where you tell me I have high blood pressure or diabetes. Same thing with your breast. We don't want you to wait until there is a big lump in your breast for us to now decide and diagnose you with breast cancer. So screening means we want to pick up things, either precancerous things or things that you may not feel before they actually manifest as breast cancer. Now, I advocate as my number one screening tool that women and men, notice I keep saying and men, women and men get accustomed to what their breasts feel like. There is no one correct way to examine your breast. However, you need to examine your breast because you are the only person who's going to know how your breast feels normally. My left breast feels very different to my right breast. Some parts of my left breast feel very different to the rest of my breast. So the key is that you examine from your collarbone to underneath the breast to the breastbone and all the way to the side. We have varying sizes of breast. That is why I'm very vague with, right? But you need to know that that is the area that your breast covers. So let's start off with the self breast examination or just examining your own breast. That's number one. When you have reached the age of 45, for normal people who don't have high risks or who are not at an increased risk of getting breast cancer, you need to start doing your mammograms. Patients ask me all the time, can I not just do the ultrasound instead? The answer from age 45 certainly is no. Okay, we're comparing apples and oranges here. A mammogram is going to be able to give you a much better picture of both breasts. It will show you what we call calcifications, little white spots that the radiologist, that's the doctor who's reading the mammogram, can take a closer look at and determine if there are things to worry about or if they're benign looking. An ultrasound is usually used to complement your mammogram. If there is something on the mammogram that they want a closer, better view of, they will suggest that you do the ultrasound and focus on that area. Now, notice I have said 45, those are the recommendations. And in my personal experience, I agree with those at 45. It was a little bit more concerning for me to ask every 40-year-old to have a mammogram from the age of 40. But 45 to me, with a normal average risk person, is satisfactory. If you are high risk, and by that I mean if you have a strong family history of breast cancer or ovarian cancer, for example, your mother, your sister, your aunt, we're talking about immediate family, then you are high risk. Usually the recommendation is that you start with your screening mammograms 10 years younger than the age of that relative who was diagnosed, okay? So that's screening so far. For younger patients who present with a lump, most times, like I said, your lump is not cancerous. Most times in a younger patient, we would advocate for you to have an ultrasound initially that will tell us if it's a cyst, which is a lump made out of fluid, or if it's something that's solid. And then based on how it feels, based on your family history, based on your risk factors, do you smoke? Are you on the oral contraceptive pill? Have you not taken a break from it? All of those questions that we ask will usually guide us as to what next. The final thing in terms of screening would be a biopsy. So there are certain lumps that we would want to biopsy, which means take a small piece or the entire thing and send it to get tested. We can find precancerous lesions, which we can treat in an effort to prevent you from developing breast cancer. Or we may find things that are not necessarily labeled as precancerous, but things which alert us that we need to keep a closer eye on you, get your screening, get your examinations or your ultrasounds done a little bit more frequently, and determine how we're going to actually manage you. So for me, those are the main components. So apart from getting your breast examined, doing the mammogram at the appropriate age, and you can have a conversation with your doctor about what's the appropriate age for you. as well as a biopsy.
Okay, so we do try to keep these talks a little interactive, and we do have take advantage of some of Zoom's features. So for those of you in our listeners, there is a chat feature. So if you have questions as we go along, you can ask the questions in the chat and I'll try to incorporate them. But now Robin will ask you a question. The question I want to do now, okay, the question that's come up is, how often do you do your breast self-exams? Be honest. So you can choose either what's a breast self-exam? You can choose once a week, you can choose once a month, a few times a year, or only when I go to the doctor. So go ahead, put your answer in, hit submit, and it will compile and she'll be able to share the responses with us and we can see. Now let me tell you something. So someone in the chat says, I have never answered a poll. What's a breast self-exam? You know, you have to be honest about those things, especially when you go to the doctor. Okay. Rule number 1, never lie to your doctor. You might think they haven't heard it, but they've heard it. Am I right, Dr. Remy?
Yes, very right. I tell my patients, unless you commit 4 breasts, I've seen it before.
So what you're telling us is you've seen 3 breasts.
I've seen things that look like 3. Yeah, so you have to commit 4 to surprise me.
Okay, let's see. I think everyone should have put their answer in by now. And Robin will be able to show us the results of the poll, I believe. That's how it worked the last time. We're all learning this technology together. And then we can move on because I want to talk about some of the risk factors you mentioned next. So as soon as we see the little... Everyone, make sure you put your answer in and hit submit. Can you share the results? Oh no, there we go, there we go. So we have a few people, 17% saying once a week, 8% saying once a month, 25% saying a few times a year, and 50% saying only when I go to the doctor. So I think we can take from that some of us need to do a little better.
A lot better. A lot better, but this is the first stage. So we're gonna acknowledge that, yes, we need to do better.
So what kind of tips would you give people for doing better? Like, you know, should you be, you know, when you're taking a shower, touching, I just touched my breast on screen, touching your breast, looking at it after your shower, or that sort of thing?
I think the first thing is to try to understand why people are reluctant to, because we do so many things at least once a week or at least once a month. You know, when we're bathing, we have to soap up or touch our breast at some point in time. But a lot of us are afraid. We're afraid to find something. My answer to that is, let's find it early so that we can do something about it. So for those persons who need a little bit more than that, I would suggest that maybe, and certainly not when you are about to have a period. So certainly when your breasts are not hurting or not, you know, feeling sensitive, etc., that you probably just pick a day every month. So maybe the 15th or the 16th, I don't know, the 3rd week, and make a conscious effort to just examine your breast. It makes sense to find something that is small. It makes sense to find something that is most likely not going to be cancer, rather than to find something, ignore it, pretend that it doesn't exist. And then when you come to us, we can't do anything about it. The majority of breast lumps, the majority of things going on in your breast are not cancer.
Okay. This brings me actually to another question that was submitted by the participants that said, how can a fibrocystis breast lead to breast cancer?
That's an interesting question. My answer is yes, fibrocystic breast can lead to cancer. However, the majority of people with fibrocystic breast will never get breast cancer. Let me see if I can explain that a little bit. So fibrocystic breast, basically, we see in ladies who are in their reproductive years. And basically your breast is responding to your hormones. So you can just imagine it kind of follows your menstrual cycle. So as you get ready to ovulate or as you get ready to have a period, the breast becomes sort of engorged as if you're ready to breastfeed. So they become lumpy, your little cysts start popping up. They become very sensitive. They look like you have milk in them. And then once you start having your menses, then they go back to normal. As you can well imagine, this causes a lot of increased activity in your breast. And I say to people all the time, when you are going along your daily activities and there's no stress, your kids are behaving the way they're supposed to, everybody's ready on time, oh, you can get everything done. The moment something starts happening that throws everything into chaos, you forget something. You forget somebody's shoe, your child forgets a book at home that they should have brought to school. Just like that, our bodies are. Once things are going in natural order, things will stay in place. As soon as there's chaos, like every month your breast start acting up, there's a higher chance that accidents will happen with the cells, which can lead to cancer. And with fibrocystic breast disease, because your breasts are already lumpy and sometimes sore, and there are different portions of your breast that feel different, it sometimes becomes very difficult for you to be able to pick up something in the breast that's abnormal. So on both sides, it poses a little bit of a dilemma when it comes to picking up abnormal lumps and being able to manage that.
Okay, excellent. So I'm kind of going to roll two questions into one, right?
Sure.
I want to know what causes breast cancer and what are some of the risk factors for a person getting breast cancer.
If we knew exactly what caused breast cancer, I think we could definitely prevent it. Okay, so unfortunately, I don't have a one answer for you when it comes to that. But like any other kind of cancer, things need to happen in sequence, a few things, at least more than four, meaning destruction to the cell, abnormalities in the cells before you actually get cancer. So our bodies are fully equipped with an immune system that once it is working properly, for the most times, will get rid of the cancer cells that we are exposed to every single day. However, we have some persons who have genetic predispositions, so they have a gene that is not working properly. That gene does not allow the normal protections of the cells to occur, and it allows cancer cells to continue to divide. Okay, so there's a genetic component that you are born with, you have no control over. And then we have other things. So we're kind of rolling into risk factors. So we have things that we can change and we have things that we cannot change. Okay, so being female is definitely the one risk factor that we cannot change. 99 out of 100 people with breast cancer will be female, but there's one male who will also have breast cancer. Okay, getting older in age is a risk factor that we can do nothing about. So we accept that the diabetes, the high blood pressure, all of these chronic diseases, including cancer, will increase as we get older. It's really just showing us that our bodies are exposed to the environment and all those things in the environment as we get older for that amount of time. The age at which you start having your periods, the age at which you go through menopause, somewhat reflecting how much estrogen you have been exposed to. Whether or not you have children, for some persons, it's a conscious decision. For others, they cannot have children. Those are risk factors as well. Things, though, that we can modify and change would be things like our diet. Now, everybody's going to ask me, what's the diet you should use to prevent cancer? I don't know the answer to that, and I don't know that everybody has an answer to that. But the general rule is to eat healthy, the vegetables, the fruits, avoiding preservatives. Dairy is up there. Sugar is definitely up there. Exercising, avoiding excess alcohol, stopping smoking or avoiding smoking altogether. My personal opinion is stress, which is one of those things that we, for the most part, can try to avoid. Stress for me is almost like the icing on the cake. So your body's already been exposed to all of these things, and then you're stressed. your immune system is not where it's supposed to be. And I think for most patients, not all, there is some stress that has occurred that can sometimes be, we think, linked to them developing breast cancer. I hope I've answered your question.
Okay. To those who are watching us on Facebook, because I did forget that we are live on Facebook, I am trying to get into Facebook so that I can see any questions that you may have. So let's get back on track. So we talked about the risk factors. Now, some people basically think that birth control pills can contribute to breast cancer. Mm-hmm. What are your thoughts on that?
Well, it has been shown that if you have been on the oral contraceptive pill, that you are at an increased risk of getting breast cancer. What has also been shown, though, is when you stop taking the birth control pill, your risk goes back to what it was before you started. So we do understand that the birth control pill is used for a variety of medical conditions, but is also used for some persons as their choice of contraception. And we respect everybody's decisions. Because if you don't want to get pregnant and that is the thing that's going to work for you, then you need to be able to make that choice. But you also need to be advised that you are already at increased risk of getting breast cancer because you are on the pill. You're also at increased risk for getting clots in the leg, lots of different things. No medication, has zero side effects. So it's a matter of weighing the risks with the benefits. So yes, there is enough evidence to suggest that there is an increased risk, but in certain conditions, we have to weigh the benefits. Sometimes we'll advise the patients to stop for a while, take breaks in between if we think the medical condition takes priority. There are a lot of people on the oral contraceptive pill who will never have breast cancer.
What about as Black women living in the Caribbean? Are we at increased risk just because, we are Black women, or are there socioeconomic factors as Black women that contributes to increased risk?
So the terms or the influence of being Black probably has more significance in first world countries because they're being compared to Caucasians, Jews, etc. The majority of us in the Caribbean are Black women, right? Okay. So we're starting off at a completely different comparison. However, what puts us probably at more risk, and not necessarily just for getting cancer, but for delays in our diagnosis, maybe the fact that we are in a third world country. So let me explain that. So our access to care, that's why I stress the self-breast examination. It doesn't cost you anything, right? It doesn't cost you anything to feel your own breast. However, when you take into consideration the cost of getting a mammogram done, $150 outside of the month of October, for some people, that is a lot of money. Okay, so even doing that, so our access, and a lot of our citizens do not have personal insurance to help to cover those costs, or medical insurance. And so the financial or affordability component is something that makes us as third world countries probably more predisposed to being diagnosed later. Okay. So in the Caribbean, I don't know that the Caucasians in the Caribbean are at less risk, because the majority of us are actually Black, but we have to look at our own intrinsic factors that make us more predisposed. One, there are cultural components. So people will look at you and say, you're too young to have breast cancer. So you have a lump, don't bother check, that's not breast cancer, don't worry about it. Or there's always a local remedy that is going to fix it. Now, again, I believe in natural things. However, I don't know what dose to advise anybody to take for prevention or for treatment. Okay, but there's always that cultural. So between financial and cultural, we are in a bit of a bind as Black people in the Caribbean.
I understand exactly what you mean. I have asthma, and about once every 2 to 3 months, someone tells me to drop a lizard in hot milk and drink it.
How does that feel?
You never heard that one?
No. How does that taste? Have you tried it?
I have a dairy allergy, a very severe dairy allergy,
That's the reason
anaphylaxis.
why? That's the only reason why you haven't tried it?
No, also because it's gross. Also because I do not like milk. I never liked milk from a child. I used to say the milk burns my stomach.
You don't mind the lizard, but you have a problem with the milk. Oh, okay, I understand now.
Dr. Remy, behave yourself. I have a problem with the lizard as well. But I'm not entirely sure the lizard would kill me.
The milk will for sure. Okay.
But you know, the people are like, they'll see your inhaler in your bag. You using that? That's not good for you.
Yep. I know.
So anyways, now that I've gone off talking about myself, we have a question that I want to get to from the participants, and then we'll move on to talking about treatment because we only have about 20 minutes left. So the question is, how often should women have mammograms done?
The recommendation so far is from the age of 45 to 55, you should be having your mammogram once a year. If your mammogram is normal for that period of time or has been normal, then once you are older than 55, you can have it again. Upon discussing with your doctor, you can move on to have it once every 2 years.
Right.
Okay.
But if you have a immediate family history with breast cancer, you need to discuss with your...
Most likely it will continue once a year.
Okay. All right. So we've talked about the risks of cancer, what cancer is, the signs and symptoms. So now I've seen that question. We're coming to it. Now I want to start talking about treatment. Mm-hmm. So you're in St. Lucia. You found a lump in your breast. What do? Go to the health center, come to OKEU?
You have lots of options, okay? For most of us as surgeons, you don't need to have a referral to come to see us. Well, certainly not in our private capacity. Mm-hmm. There's a requirement for the clinics at OKEU that you need to have a referral. So that referral can come from your health center, from your general practitioner. But if you find a lump, you need to go to wherever it is that you can go to. So if the health center is cheapest for you, you go there and they will refer you. I would like to insist that if you have a breast lump and you want somebody to sort it out for you, that you insist that you are referred, okay? Too many times I've heard patients say, oh, they told me it wasn't anything important or anything to worry about, so I didn't do anything about it, okay? Get it checked out. And the best person to do that is most likely your surgeon, okay? But other than that, you can walk into your general practitioner, you can walk into a surgeon's office with your complaint that you have a breast lump, and we will see you.
Okay. I've also heard people say, they told me it was nothing. And I'm like, they who? They the surgeon? But we have a question in the chat about, I wanted to talk about the different types of treatment first. So we have, what are the stages of cancer? Mm-hmm. And I guess that would tie into how it is treated, the different types of treatment.
Okay, so anybody who's diagnosed with cancer, breast cancer being no exception, is going to have to be taken care of by more than one person, most times doing more than one thing. So for breast cancer, there is usually a surgery procedure that has to be done. We can discuss that. There is almost always chemotherapy that has to be done. There may be radiation to be done. There may be hormonal treatment after those three things to be done. Based on each individual case of cancer and individual person, because you can well imagine your treatment of an 80-year-old with breast cancer will differ from a 50-year-old with breast cancer, okay? And each cancer is different. So depending on what you come in with, you are going to have one or all or some of those treatments that I just mentioned. The treatment is definitely related to the stage. By stage, I mean how far the cancer has spread, which is always the first question that patients ask when they are diagnosed with breast cancer. Doc, what stage am I at? The stages go from 1 to 4, where 1 and 2 are considered early breast cancer, 3 is considered advanced, and 4 is considered metastatic, or it has spread to other parts of your body. The outcomes, and again, first world countries versus third world countries. So in America, for example, patients who come with stage 1 disease have an almost 98% chance of survival. Okay? In our setting, it's not that high, and we don't usually see a lot of patients with stage 1 disease, and that is a lump that is less than 2 centimeters. Okay? This is 2 centimeters. If you look at your finger, the first line right there, where your finger bends, that's 2 centimeters. Stage 2 is 2 to 5 centimeters. Stage 3 is more than 5 centimeters, or if you have glands under the arm, or if you have involvement of the skin. And stage 4, it doesn't matter what size the lump is, it could be 0.5 centimeter, but if you have spread to the liver, the lungs, the brain, the bone, it's stage 4 disease.
Okay.
Okay.
Okay. So, meanwhile, I'm a results oriented person. So I'm just like, what do we do about it?
Mm-hmm.
That's personally me. But I understand a lot of people need to understand what's going on. Okay, so now we have a question that's been asked about what are your thoughts on preventative mastectomies?
I think that when we say preventative, let me say that I think the more medical term will be prophylactic, which means the same thing. We're removing the breast before it becomes a problem. I think that preventative/prophylactic mastectomies are reserved for persons who have a positive genetic predisposition. So we're not talking about just a family history, but we've actually tested you and you are positive for one of those genes associated with breast cancer. Because we know that if it's positive, there is, depending on which one, a 60 or an 80% chance, not 100%, a 60 or 80% chance that you will develop breast cancer. Okay? So for those persons, and of course, the person that we all refer to is Angelina Jolie, who had a strong family history. She was also BRCA positive, and for that reason, she removed both of her breasts. Genetic testing costs about $3,000 US. And it's not available here, although I think we can actually send your samples away, but you will have to pay the $3,000 US for it. And in those cases, that's when I would recommend, for sure, having the conversation. However, having said that, there are patients who have a very strong family history, and not knowing is making them extremely anxious because they don't want to get breast cancer. Even if we remove your breast, there is still a 5% chance that you may get breast cancer because we leave back 5% of your breast tissue. We have to. If we want the skin that we have left behind when we remove your breast to heal, we have to leave a little bit of tissue. So for patients who remove their breast, there is always that small 5% chance of a recurrence. So your risk is not ever 100%. However, it would make it a lot easier to examine the breast and detect something if it shows up in the breast. So for me, I am for prophylactic mastectomies in the right patients. I would not advise just anybody who says to me, I'm afraid of getting breast cancer, to take off your breast. I mean, you may want to have children, you may want to breastfeed. There are so many other things. And again, doing that does not make your risk 0%. Close, but not 0%. So I think it's a conversation, but in select persons.
Okay, I have a question from the participants that I think is actually very widely thought of in St. Lucia. The person asked, do you think that sometimes the radiation treatment contributes to the tumors growing?
When you say radiation treatment, are you talking about the mammogram, or are you talking about the radiation as a form of treatment?
Now,
I can try to address both.
I would say address both, since I I'm not sure. But
A
I
lot
was
of
just thinking
persons,
that I have heard both.
right.
So
So
among the people, the same people who said to drop the lizard in the milk.
So it's a common concern from persons, either that the squeezing of the breast to do a mammogram is what causes cancer, or the exposure, sorry, to radiation. There is no doubt, just like an X-ray, that a mammogram exposes you to radiation. What they have decided, or shown rather, is that the amount of radiation that you get from your mammogram is almost equivalent to what you get naturally 3 months, over a 3-month period of time. So your exposure is extremely low. There is radiation exposure, but it is low. And so the benefits of doing a mammogram once a year or once every 2 years outweighs the risk of your exposure from radiation, having done a mammogram. If you do a CT scan, those levels of radiation exposure are through the roof. Okay, even doing your x-rays are higher than just doing a mammogram. So yes, radiation though, as a form of treatment, which is very different to radiation from getting x-rays or even your cell phones or the microwave, that kind of radiation that we hear about, or just from the UV light from the sun in the atmosphere. Radiation is a specific type of treatment that we apply to the breast or to the area where the breast was, usually after you've had surgery. So for patients who have breast cancer who opt not to have the entire breast removed, and these are, again, patients who meet the criteria for having that surgery, have to have radiation as part of their treatment. You do not get the option of choosing taking off the entire breast or taking off a piece of your breast, and that's it. If you're taking off your entire breast, usually that is one option. If you're doing a lumpectomy or a portion of the breast, it has to be with radiation to what you are leaving behind. That is basically shining X-ray beams in the area where cancer was to burn the cancer cells. So that treatment we know delivers a lot of radiation, but it is for treatment as compared to doing the mammograms.
Okay, so we have about 10 minutes left, and I want to highlight what treatment is like, and also what kind of support someone who is diagnosed with breast cancer in St. Lucia can fibromyalgia brain can expect can expect to get if they need support.
Support for a lot of people, I have found in St. Lucia, being president of Cancer Society, support for a lot of people is initially financial. The cost of your treatment can run anywhere from $300 a month or a cycle to as much as 10,000-15,000 US dollars for radiation. And that's only one portion of your treatment. So it varies, but for a lot of people, it's a lot of money that you have to come up with now. Okay, this is not like high blood pressure where you refill your tablets, you can do a week and then go back and get the medication, and whatever you get every week, you have to put the money up front and get your treatment done. And if you have delays, then that obviously is going to affect your outcomes and how well your treatment goes. In St. Lucia, as far as I know, so there is an oncology department where you will most likely access your treatment. So you will get your medical support from there. There are financial associations or places that you can apply to for financial assistance. So there is the NCF, there is the Medical Assistance Fund through the Ministry of Health. The Cancer Society, we are a voluntary, non-government association that depends on persons donating for us to actually be able to provide any kind of assistance. And I believe for Faces of Cancer, but I think they usually, in terms of financial, select maybe 1 or 2 cases and help you through your entire treatment. So those, as far as I know, are the main places that persons can access financial assistance, apart from having their own fundraisers. The other kind of support, which is just as important, is family support, and support the patient as they go through this process. So persons who've had or gone through the journey themselves, who can sort of hold their hands and tell them what to expect and be able to have that conversation. As a doctor, I have found that I can have the conversation up to a point. I thankfully have not been diagnosed with any cancer. And there are a lot of things that I cannot connect with, with a patient. I can give you the science, but I can't tell you experiences. So there are a lot of these support groups. When I say a lot, sorry, there is Faces of Cancer, and I think that is one of their areas where they have a lot of their members who are survivors, the Cancer Society as well. And I think even for families who have to watch their family member go through cancer, not knowing what to do, not knowing how to support them, it's extremely important that they have that support as well. So we are very limited in terms of support systems, and that is definitely somewhere that we can improve.
Okay. So after someone goes through all of that, what are the chances that the breast cancer will come back?
That is dependent on the stage that you presented with at the beginning. It is dependent on the age of the patient, the comorbidities. When we talk about comorbidities, we're talking about you're diabetic, you have heart issues, you have those kinds of things. It's also dependent on your treatment. It depends on if you were able to access and get the treatment that you required for that stage. It depends on if you were able every 3 weeks to come back in and get your next round of chemotherapy. It's dependent on having completed your chemotherapy, there was no delay to you having your surgery, or the other way around, or having to travel outside of St. Lucia to get radiation. So it's dependent on a lot of things. If everything was in place and you didn't have to depend on all of these things, stage one, like I said, the success or survival rates range between 95 and 98%. Stage two, still above 90%. Stage three, we're talking about 60 something percent. Stage four, we're looking at maximum 10% in terms of survival, by which I mean at the end of 5 years, that's the number of persons who will be alive and cancer-free.
Okay. So you brought up something that I wanted to highlight before we wrap up. You brought up having to travel outside of St. Lucia. So you mentioned surgery, chemotherapy, radiation, or a mixture of that. Are all three of these available here, or are some of them you only can get it if you travel?
No, you will not be able to access radiation therapy here. Most islands, most places don't have radiation, but there are select islands in the Caribbean that patients can access. There's Guyana, there's Trinidad, there is Martinique, there is Antigua, and then we start looking at places like the United States where you would probably be referred to breast centers or oncology centers to get radiation done. Of course, the more advanced that your radiation is, the more expensive it's going to be. So places do offer radiation, but we're talking about radiation that is not the most recent. It works, but the side effects that you will get will be higher than for somebody who goes to somewhere where the radiation costs 20,000 US dollars.
Okay. So real quick, I did kind of gloss over that question. People do get concerned about side effects, like their hair falling out during chemotherapy and that sort of thing. Can you just real quick just tell us what are some of the side effects and what are some of the ways patients can expect to be supported through those side effects?
So most times the oncologist anticipates, like all of us who are surgeons or working with cancer patients, why it is you get these side effects, and we can usually give you medications to tide you through. So chemotherapy works on very active dividing cells. So as we mentioned in the beginning, cancer cells are rapidly dividing, they're doing their own thing. So chemo will be targeted at those. Our hair and our nails and the lining of our stomach, colon, intestines, all the way down are also very rapid. You bite your tongue, by later today, it's fixed. So the chemo for now cannot differentiate which one is cancer and which one is your hair, etc. And that's why you get the side effects. So normally you will be given things to protect your stomach when you're going to be going through chemotherapy. In some places, which cost a lot of money, you will be given things to boost your bone marrow so that your cells continue to produce things for your blood count, your platelets, etc. But we cannot do anything about you losing your hair. We can help with the other things. For example, the pain in the mouth, the ulcers that you might get in the mouth, the vomiting, the diarrhea, by expecting them and giving you medications to sort of minimize those effects. But those are the direct effects of the chemo, targeting cells that are acting like cancer cells and not being able to differentiate between the two. So we expect those.
So what you say, I heard you say nails. I'm very vain about my nails. So the nails come out too?
No, they don't come out. They turn black or they get lines across them. They become very brittle. So yes, you can look at a patient who's getting chemo and you can most times tell based on their hands that they're getting chemo.
Okay. So I can deal with those.
It'll go back though, like your hair, it will go back.
I can deal with the hair growing back. I was just like, did the nails fall off? She said nails. I heard nails. I am vain about these.
No, not fall off.
Okay. So this has been an enlightening talk. It's almost 7 o'clock. So I just want to do a quick recap. So you said, look at your breasts, touch your breast, feel your breast. That's the most important thing we can do. And you also said, try to decrease your risk, avoid smoking, quit smoking, or don't start smoking in the first place. Eat vegetables. And if you see any changes, go to get a healthcare practitioner. And based on your risk, do your mammogram either 45 if you have no risk, or earlier depending on your risk as discussed with the doctor.
Yes.
So I feel like that's the most important thing. If we take nothing else from this, do you think there's any other piece of advice that you can put for the people? Because I know a lot of people have anxiety about getting breast cancer, the big bad breast cancer. Do you have any other final advice, any words you'd like to leave us with about it?
Unfortunately, breast cancer is the number one cancer in our women in St. Lucia. You will hear 1 in 8. Those are US figures or global figures. Our local figures suggest 1 in 16. So I think there are 20 participants on this forum. One of us will get breast cancer in our lifetime, okay? What you can do is the prevention part, which we advocate strongly for. So exercise, eat properly, try as much as we're going through stressful situations every day, find half an hour to reduce that stress. Talk to people. Your mental health is important. Examine your breast. It costs you nothing. A mammogram is a lot more expensive. Like you say, there's a slightly increased chance you're going to get some radiation. Examine your breast. We much prefer that you come in, having examined your breast, and find something this small and fix it rather than wait until it's much bigger. It's going to be a lot more expensive. You're going to have to travel. Your outcomes are not going to be as good. So I want everybody to be empowered. If there's something going on in your breast, you're not happy that somebody has said to you, don't worry about it, you're too young, don't worry about it, it doesn't feel like anything. It is really up to you to determine what is going to happen to you. So take control, be insistent that your concerns are taken seriously. Okay, at the end of the day, most likely it is not going to be breast cancer, but at least you know, at least you've done your part.
Thank you so much. We have a lot of people in the chat saying thank you, saying it was a wonderful session, very informative. We know that you are very, very, very busy. You have how many pots on the fire that you have to take care of. And we really appreciate you taking time from your busy schedule to come with us. The chat is singing your praises. I don't know if you can see them. If you can see the chat, they are singing your praises. This was very easy to understand. And thank you so much for taking time and for answering all of our questions. We got through most of the questions. So everybody, thank you for coming, for showing up, and for asking such insightful questions. Our next talk will be I don't know the date. The last Wednesday in November, we'll be talking about holistic health. So we've already talked about STIs, PCOS. It'll be on November 25th. and we'll be talking about how to take care of ourselves as women. So look out for on our social media for the link to sign up for that. It should be out in 2 weeks, if everything goes according to plan. And that's it. Y'all have a great night. Thanks for coming. Bye. Y'all can unmute yourselves and say bye.
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 Good night.
Good night.
And I have lost. Oh, there we go. There we go. Come on, phone. There we go. Bye, everybody.
Bye-bye.